My name is Eric Tamm. My colleague is Dr. Sanaz Javadi. We're from MD Anderson. Thank you very much for coming. It's a privilege for us to be able to share with you our experience from MD Anderson. What we'll be talking on is an update on pancreatic cancer from imaging through reporting. So this is our disclosure. So I'm going to start off with a discussion of imaging techniques, and what you're going to see here is going to be drawn from the National Comprehensive Cancer Network Guidelines, otherwise known as NCCN 2019. These are easy to get to. Just go ahead and Google. It's about a 120-page document, but it is very nicely laid out with flow charts, a lot of data, background that's very helpful. So we'll be drawing from that because it's basically a document created by specialists from a wide variety of areas, including radiologists. We'll cover things about, for example, beyond imaging, recommendations on biopsy, genetic testing, which is becoming more and more important in this field, an update on current management. This will be sort of oncology light, but at least give you an overview of what our clinical colleagues are doing in terms of therapies for this cancer. Then my colleague Sanaz will then go into the American Joint Committee on Cancer T&M staging changes that occurred in 2017, the current categorization, particularly borderline resectable disease, and then go into reporting, where we'll describe about how you manage primary lesion, particularly a description of vasculature, nodal involvement, and metastatic sites. So, how to image. Imaging has become such a crucial part that the NCCN felt it was necessary to put into their guidelines something to create more standardized imaging. First of all, 64 detector row or better multi-detector CT. And this is drawn from a paper that was multidisciplinary, including multiple radiologists from the Society of Abdominal Radiology, published in 2014 from Al-Hawari. Mahmoud is actually, I believe, on the NCCN panel. The other recommendation, dense contrast, 300 or better for iodine. You can use a lower concentration if you're using like low KVP techniques or dual energy, but what I would say is we try to use that instead to boost the visibility rather than trying to economize on contrast. A fast injection rate, 3 to 5 cc's per second. At our institution, we have IV teams who place robust IVs to allow us to do so. And probably very important is imaging during the late arterial phase. For a 30-second injection duration, it's about 45 to 50 seconds after the start of contrast injection. As you can see up here, 120 kVp image equivalent. You see nicely about here tumor, but you have some filling of veins. That's okay. The problem is when people image at the pure arterial phase. 20 seconds, beautiful depiction of vessels, but the pancreas is not enhancing at all. You cannot see the tumor. It's basically an unenhanced pancreatic scan. Portal venous phase, about 65 to 70 seconds, and then acquire the images as thin as possible. The reason being is that you can then create multiplanar reconstructions with high detail. These multiplanar views, the coronal, are particularly helpful. In fact, when we do multidisciplinary conference, our surgeons now particularly ask me to switch to the coronal images to show the celiac, its trifurcation, the SMA, and to show how much the tumor is infiltrating down into the mesentery and how broadly across the abdomen. The other thing I would sort of point out here is, again, here's with dual energy, here's low KVP. These really do help make the tumor more conspicuous. I go to that to see how big the tumor is, where it's located, if it is present, but it is also very helpful in multidisciplinary conference because this is easier to see across the room from a projector with having that boosted contrast than it is looking at a conventional like 120 kVp late arterial phase image. So current management. First step, biopsy. The recommendation is if there's going to be neoadjuvant therapy, treatment before surgery, chemotherapy, radiotherapy, to biopsy and confirm that a tumor is definitely present. There are rare circumstances where the biopsy may be negative, but they think it is so much that it's likely a tumor that they will go ahead and treat anyway, but that's rare. They really try to get that tissue. But the other reason is, we'll see a bit later, is genetics. The preferred approach from the NCCN, endoscopic ultrasound, felt to have better diagnostic yield, considered to be safer than trying to do percutaneous, lower potential risk of peritoneal seeding, and it has a high sensitivity and specificity. Genetics is becoming increasingly important in this field. In fact, I know at our institution, probably several others, they are banking tissues that they get from biopsy and storing it to be able to use for as genetic testing and new information becomes more available. What they're recommending for locally advanced or metastatic disease is testing of the tumor itself. The idea is to identify non-heritable mutations that are unique to the tumor. Some of these may be actionable. They're very limited, but hopefully the pool of actionable mutations will grow. They are recommending for any patient germline testing for those who have confirmed pancreatic cancer. These are the ones that are heritable mutations. And genetic counseling is recommended for patients who test positive for a pathogenic mutation or who have a positive family history, regardless of whether a mutation has been identified. Now, Sanaz will go into this in more detail, but just to give you up front, we can divide pancreatic cancer into three broad categories based on imaging. What has been called very clearly resectable. No obvious involvement on imaging of vessels by tumor. Either there's fat or clearly normal parenchyma up against the vessel. On the far right, what is considered currently to be definitely unresectable. 360 degrees or way beyond 180 degrees of involvement of crucial vessels like the SMA, the celiac. That may change in the future. There are institutions who are being very aggressive. There are some places where what has been considered to be locally advanced unresectable are taking advantage of some of the changes coming with current chemotherapies. So it's something to watch. In the middle is borderline resectable, and my colleague will go into that in more detail. So the recommendations when you have the clearly resectable, if the patients go directly to surgery, and some institutions are giving preoperative therapy to that group, but if they go to therapy, is that they should get 6 months of adjuvant chemotherapy. Their recommendation is modified Folfirinox. It's less aggressive than full-blown Folfirinox. Probably the reason is these patients are sick after surgery, so they're trying not to be as impactful on the patient. There are other alternatives. There's Gem+Abraxane and capecitabine and other monotherapies that are more gentle. That was the recommendation from ASCO, and the NCCN recommendations mirror that, which are modified Folfirinox or Gem+Abraxane and capecitabine. Radiotherapy is somewhat controversial. The goals of radiotherapy are sterilize the margin of tumor up against the vessel so that you're more likely to get a margin-negative resection, provide local controls to try and delay progression while you're doing these therapies, while at the same time minimizing damage to other organs. In the palliative or recurrent setting, the goals are different, of course. Alleviate pain, control the tumor so that you can avoid symptoms like bleeding or obstruction. The recommendation in this group is to try and put a biliary stent in place before they do the therapy. At our institution, we also try to make sure the imaging is in place before they put in any stent. And in the case of SBRT, there's a particular emphasis to look if there is invasion of bowel. For metastatic or locally advanced preferred regimens, if the patient is robust, has a good performance status, is to use Folfirinox, modified Folfirinox, plus minus chemoradiation. Our institution, there's radiation is definitely involved. The alternative, a little bit less aggressive, Gem+Abraxane plus albumin-bound paclitaxel plus minus chemoradiation. Notice a pattern. You're going to see Folfirinox appearing in almost all of these. For BRCA1-2 or PALB2 mutations, Folfirinox, modified Folfirinox plus minus chemoradiation, but these tend to be more sensitive to platinum-based agents, so you'll see them comment on Gem+Abraxane and cisplatin, particularly for this group. And if there's poor performance status, less aggressive therapies like Gem+Abraxane alone, capecitabine, or CI5FU. But I think what I want you to sort of get from this, because this can become a soup of things, notice how Folfirinox keeps popping up, and that you'll see as the next line for many of these, this Gem+Abraxane plus albumin-bound paclitaxel. For neoadjuvant, the NCCN recommends these patients should be in trials to be able to obtain as much data as possible. They should consult at high-volume centers. And again, Folfirinox, modified Folfirinox, plus minus chemoradiation, and Gem+Abraxane plus minus the albumin-bound paclitaxel. For BRCA, the same things you saw recommended before. And again, looking about the platinum-based agents. So what we're seeing again is when we treat, The periphery tends to die off rather well. The center tends to viable tumor. Key is it's not like, this sort of suggests there's a solid core of cells. It's not. They're nests of cells that are distributed. You get a negative margin, so the prognosis is improved. Notably improved if you have a negative margin on microscopy. But the challenge we have currently, and that we need to develop in this area for research, how do we tell apart what's viable and what's non-viable? What is a marker that tells us how much of it is dead or how much is still living there? We don't have that yet. And it has an effect in terms of judging radiographically. At our institution, we looked at a study of 122 patients. Only one of the 122 changed from borderline resectable to clearly resectable disease. Tumor actually moved away from the vessels. And all the rest, the relationship stayed the same. Tumor may have shrunk or didn't shrink, but yet when most of them went to surgery, they did relatively well. The median survival was 33 months for those who went through this. And again, we can't tell apart viable from non-viable. And we tend to, if we just went based on what was contacting the vessel, we'd be saying that tumor is still up against the vessel. What I've heard from our surgeons is no matter how far or close we think the tumor is, the margin is always within millimeters. They dissect right up on top of the vessels. But by doing preoperative therapy, they're able to get a negative margin. The speculation is that the issue we're dealing with is that stroma dominates this tumor. It's mainly, there's a lot of fibrous tissue. You have nests of cells, so when you treat, these nests get less dense. But the overall periphery of the tumor still is extensive as it was, and sometimes may even get a little bit larger. So this will be a brief overview on surgical techniques. The most heavily used graft is the vascular bypass graft. The key here is there patent lumen above and below so that you can do what you see on the right, be able to restore flow. Currently, they do not have the technology to connect a graft to multiple branch points, single lumen above and below. They did find at our institution if you ligate the first jejunal vein because of the slow growth of a tumor in general, what happens is they develop enough collaterals you can ligate the first jejunal vein as long as you restore the patency of the SMV. Our surgeons have also over the years told me things that they would like me to identify. One of these is the inferior mesenteric vein. As they try to restore drainage from the bowel when they're working on this, they like to know where the IMV empties into as they do their planning. So what I look for is I go by the rectum, I try to follow up where the veins drain, identify the IMV, and follow it up. It can drain to one of three places: splenic vein, splenoportal confluence, or SMV. And I just simply note in the report the IMV drains into the SMV. And here's an example on the right. This was a MIP to be able to show you more of the full length of showing how the IMV emptying into the splenic vein. They also like to know the course of the first jejunal vein. If you come down from the splenoportal confluence, you'll see this large vein draining off posterior to the SMA. Most of the time posterior. It actually is at this point the SMV is no longer the SMV. It becomes the ileal branch of the SMV. A lot of us still try to think it's sort of the SMV. If it goes anterior to the SMA, the operation got a whole lot easier. So our surgeons like to sort of know up front if we tell them that. Now our surgeons are looking at all these images, but by putting all of these things in here, their PAs can actually start triaging their patients just by looking at the report. The last graft I'll address is a common hepatic arterial graft. You can have up to encasement of the common hepatic artery as long as you have a jump-off point 1 centimeter from the origin of the celiac trunk that is patent that they can attach to, and as long as the left and right branches are left free as well. So as long as tumor hasn't infiltrated that far up. If there's enough laxity, you can do a direct end-to-end anastomosis, or they'll put in place an interposition graft. It's not used that often. If it involves the common hepatic artery, it's usually pretty extensive, but this is the arterial graft that is done. You may hear at other institutions a variety of other grafts that are being used, some other things that are being tried. This is all very, very early. There's a lot to learn. So I would expect in the few years coming up to come, you will see more aggressive surgery being done. And I'm going to turn it over now to my colleague, Dr. Sanaz Javadi.
Thank you, Dr. Tamm. So I'm Sanaz Javadi from MD Anderson. I'm going to continue the talk on staging of pancreatic cancer. So the new staging that came out in 8th edition in 2017, the T category is revised from being descriptive to size-based definition. So the size-based classification was able to stratify overall survival better than the prior descriptive category classification. And also in resectability is removed from the T4 category since the definition of resectability is now is not consistent among institutions and evolves with advances in surgical technique. And it's based on basically the prognosis. Size-based affects the prognosis, describes prognosis better than the prior staging. So the main stage difference now is the change in the size that affects T1, T2, and T3 staging. So if you have the tumor less than 2 centimeters would be T1, and that further subdivides in T1, A, B, C. T2 is when the tumor size is 2 to 4 centimeters, and T3 is when you have a tumor more than 4 centimeters. What has not changed is the T4 category, which is not based on the size. Still is not based on the size and is based on the vascular arterial involvement, like celiac involvement of the celiac, SMA, or common hepatic artery. The changes in lymph node, the N status is addition of N2, because there was a few studies showing that the number of metastatic lymph nodes affects the prognosis. So now they have N1, which describes if there is only 1 to 3 metastatic lymph node, and if you have more than 4 metastatic lymph nodes, that would be considered N2, which is like poor, worse prognosis. M is obviously unchanged as when you have distant metastatic disease. The borderline resectable disease is an area that is changing, and there's no consensus among institutions and societies. We're going to go over this. So there are some agri terminology to describe the extent of vascular involvement. It is considered abutment of a vascular structure when you only have 180 or less than 180 degree involvement, so that's considered abutment. Or if you have more than 180 degree involvement of a vascular structure, it's called encasement. So we need to be consistent and be aware of what is when we describe our venous or arterial structural involvement. So like this is an image of SMA abutment. So you can see that there is abutment of SMA and SMV, and here there is more than 180 degree involvement of the SMV, so that's basically encasement. So in our institution, what is considered borderline resectable is when we have abutment of the SMA and celiac axis less than 180 degree or equal to 180, or encasement of a common hepatic artery. As Dr. Tamm described, you need to have like at least 1 centimeter from distance from the origin of the celiac, so to be able to do the anastomosis. Or if you have a short segment venous occlusion or involvement of a venous structure, something that it would be basically graftable. They usually use the internal jugular vein to do that. And if there is a questionable liver lesion, that will be followed up. So here, borderline resectable disease is an example of a SMA. It's a baseline study that shows the SMA abutment, and 6 months later the tumor is smaller. There's still a little abutment. So this is considered borderline resectable. It's an example of a celiac artery abutment. You can see that there is almost 180 degree abutment of the celiac. That it's a coronal image. That's also considered borderline resectable. Isolated encasement of a common hepatic artery, that's another one, and you have like 1 centimeter distance from the celiac axis. Venous SMV involvement, and when you have an open, as Dr. Tamm described, or you need to have an open above and below vein to be able to do the graft. Too small to characterize hepatic lesions are considered borderline at the baseline. So we need to follow them up. If they end up growing and enlarging and they are clearly metastatic disease, then those patients will not be considered for surgery. But if they stay stable or they get smaller, then they would be considered for surgery. So as I said, there is no consensus about what is considered borderline resectable. It varies from societies and among societies and institutions. But what is the most controversial is the celiac axis abutment and encasement. So NCCN in 2014, those both were considered unresectable. But since then, we've come a long way, and now they're considering them borderline resectable. In MD Anderson, celiac abutment is considered borderline, but encasement is considered unresectable. Most of the surgical societies, they consider them for unresectable. So that's why it is important for us to provide a precise description of vascular involvement and make a differentiation between abutment and encasement, because these patients would be either considered for surgery or not. So what is radiology reporting needs to go over? Obviously, T-staging, as I mentioned, is based on the size of the tumor, N, lymph node status, location, the size, the number matters, and if there is distant metastatic disease, and all the other findings that will be on this scanner. So the primary the pancreatic mass, the very first thing is the location, and then morphology, enhancement characteristic, if it's a hypodense, isodense, size, which is now the most important one, and also the effect of the mass on biliary ducts. If you have an intrahepatic or extrahepatic biliary ductal dilatation, pancreatic ductal dilatation, so these patients would go for a stenting. And then if there is extension of the mass beyond the pancreas and involvement of the adjacent organs, if the mass is in the head, there's a good chance that there's duodenal involvement. And if it's in the tail, it can go to the pancreatic, splenic hilum, it may involve adrenal. So all of that it's important to describe. And also, you need to mention the background of the pancreas. If you see punctate calcifications, there's evidence of chronic pancreatitis. And if there is, a lot of these patients will present with acute pancreatitis, so you'll have enlarged pancreas, fat stranding, and all of that. And that makes staging difficult. So these patients would need short-term follow-up after the resolution of their acute pancreatitis to have a better and accurate staging. So this is a template that is suggested by NCCN. Basically, it goes through over the same things that I talked about: appearance, size, and location of the tumor. If there's ductal dilatation cutoff, and if there is biliary tree dilatation. The other important thing are the vessels. So we need to know the anatomy, the arterial anatomy, and the relationship of the tumor with these all the arterial arteries, basically. And the other the other important thing is being aware and being descriptive of the arterial anatomic variants, because that would affect the surgical planning. If you have a replaced left hepatic artery, which is arising from the left gastric artery, or a replaced right hepatic artery arising from SMA. And then again, venous structures, we need to be aware of where IMV drains and all the jejunal veins, as Dr. Tamm described. So that would affect their surgical planning as well. It is important to have reformats, and they can be very helpful in multiple occasions. So this is an axial CT that you can see the celiac and common hepatic artery involvement, and this is a coronal reformat that clearly shows the encasement of the common hepatic artery. A lot of times it's difficult to pick abutment of the common hepatic artery on axial because the tumor is growing from under and there is like undersurface abutment of the common hepatic artery, which you would better see on the coronal images. Imaging findings in setting of chemoradiation. So after chemoradiation, after the treatment, the tumor most of the time shrinks, but there is some findings that we need to be aware of and be descriptive of. If there's a vascular involvement, it can be in form of like fat stranding or solid soft tissue abutment or involvement. Pre-therapy, the fat stranding may be secondary to tumor, pancreatitis, or inflammation simply because they place the biliary stent. And after therapy, if this fat stranding, it is important to notice, is it continuous with the tumor or discontinuous? And if it's discontinuous, there's a better chance that it's not tumor. And if the fat stranding is new in a setting in a tumor that is shrinking, it just might be because of the radiation changes. It's just a local edema post-radiation. And these patients, after chemotherapy, they have a lower chance of having margin positivity after the chemoradiation. So this is an example of a baseline that you see the tumor. There is a solid component and a little fat stranding around it abutting the SMA. And after chemoradiation, that has decreased. But still, there is a soft tissue and a little like fat stranding. This patient went to surgery and had negative surgical margin. The other things that are important to mention, if there is like venous thrombus, including like portal vein thrombus, like you can see the portal vein thrombus in this patient, if there is a SMV thrombus, and also important to mention the varices. So these patients, like with gastric varices, are prone to having GI bleedings. This is a template, again, suggested by NCCN for a description of the vascular arterial involvement. So they want to go over SMA, celiac, common hepatic artery, and all like in details if there's soft tissue, if it's just stranding, if it's less than 180 or over 180, and also the arterial anatomy. And this is a template that they're suggesting for description of venous structures. The main one are main portal vein, SMV, and then description of the venous collaterals. So at MD Anderson, we have this template, and we go over in more details, including splenic vein, confluence, and then abutment and encasement of those structures. And it's also important to mention if there is like occlusion, because a lot of times these pancreatic cancer results in venous occlusion, and that would affect what they would do for surgical planning, or if they're not considering the patient for surgery. The lymph node status is important. As I mentioned, this is a prognostic factor. So the location and the number matters when you're reporting. The location like portohepatis, common hepatic artery, portocaval, celiac, splenic, hilum, and mesenteric, and retroperitoneal. These are the locations that are most of the time pancreatic cancer would go to. So they would take the lymph nodes if they're in the surgical field. But if we see that abnormal lymph nodes outside surgical field, that is important for us to mention because that would change, again, their surgical planning. Particularly left side of the SMA, that's not a common area for them when they're doing surgery. But when we mention that, they would go after those lymph nodes. If there's like gastrohepatic recess, retroperitoneum, or outside abdomen, if you have a like supraclavicular abnormal lymph node, they'll do a biopsy before considering the patient for surgery. And then the size and the appearance of the lymph nodes, if they are necrotic, so that would guide for biopsy. And the metastatic sites, obviously, liver is the most common site for pancreatic cancer to have distant metastases. Peritoneum, in peritoneum, you can have very non-specific findings like ascites and some fat stranding, and if you have like nodules, and then that's more specific. But these are things that to keep eye on. Omental caking, you'll see it in very advanced. But a lot of times we just see fat stranding and nodules, and then in follow-up you see if they're growing or not. Lung, bone, and those are other areas that would pancreatic cancer metastatize to. And if you have, like, on the very first exam, if you have, like, some suspicious indeterminate things, that findings will mention, so we have, like, keep eye on those basically on the follow-up imaging. NCCN, again, suggesting this template of talking about liver, peritoneal, SIDs, lymph nodes, and extrapancreatic disease involvement. And in the impression, they want you to mention the vascular involvement and metastases. So in conclusion, in 2019, there's continued evolution of management of the pancreatic cancer. The guidelines try to establish uniformity in imaging for staging of pancreatic cancer. And the purpose of the staging now is prognosis rather than management only. And categories of clearly resectable, borderline resectable, and unresectable is developed based on in context of preoperative therapy. But again, this borderline resectable is an area of evolving, and it's not. There's no consensus in different institutions, between different societies and institutions. And radiology report needs to be precisely describe vascular involvement, meaning abutment, encasement, or occlusion. And also there are some templates that are available to guide reporting. So these are what we basically talked about. And thank you so much for listening.